Dr. Barber, thank you so much for taking the time to talk with us today. I really appreciate it. My name is Kristen Feldman. I'm the acting chief medical officer at Afaxys, and I'm also a practicing gynecologist with Carolina Gynecology. So it's really nice to meet you, and thank you for your time.
Nice to meet you too, and thank you so much for having me. I'm a professor of sociology at Indiana University, and I'm also with the Kinsey Institute, where I'm a senior scientist. My work focuses mainly on a group of young women who were 18 and 19 who I followed over time for 2.5 years. And so my research team and we every week checked in with them and asked them about 5 minutes of questions about their relationships in the past week. The study was really about what kind of relationships produce pregnancies in those young ages, and are those pregnancies that those young women wanted or that they would have preferred to avoid.
Sounds like you got some really interesting information from those patients. One of the things I wanted to ask you about is how partners can start a discussion about contraception. So from a sociology standpoint, when we're thinking about relationships, that can be a very difficult conversation for people to have. How can partners start talking about some of these difficult negotiations, or sometimes difficult negotiations, regarding contraception?
So one thing I found with this data set is that people in the more serious relationships were much more likely to discuss contraceptive use. They were much more likely to discuss whether they wanted a pregnancy. And so it's much more difficult for women in new relationships or in relationships where they're not sure whether their partner is monogamous or not, or they haven't agreed to be monogamous. I just think, beginning conversations about family or about, future goals related to family and childbearing can be one way to ease into contraceptive use.
So it's not only about avoiding pregnancy, or perhaps not avoiding pregnancy, but it's also about the timing, it sounds like. So maybe that needs to be worked into the conversation as well.
We find that women who want to start their families younger they don't want to adopt LARC methods, for example. They don't want an IUD because, if they think they might be starting their families in a year or two, they don't want to have to go and have that IUD taken out. And so they're much more likely to be negotiating for short-term method use.
As a practicing OBGYN, I find that patients don't always have a binary view of contraception or pregnancy, meaning they don't always think, I definitely 100% want to get pregnant, or I definitely 100% do not want to get pregnant. That sometimes there is some mixed feelings maybe, and some feelings on a spectrum. And I think, to your point, that's where a long-acting contraceptive may not serve a patient as well in that particular circumstance. Now, if she does feel really confident that she doesn't want to get pregnant, I think it's a great option for a lot of people. But if she wants to maybe adjust the timing on conceiving, she might be more interested in a short-acting method, is what it sounds like you're saying. Changing gears a little bit, can you tell me how you think making contraception more affordable can improve sexual health overall for people?
Yeah, I mean, access in terms of making it easy and in terms of making it cheap certainly is an important determinant of whether women are able to keep taking the method they've chosen. There's this constellation of things about most existing methods, right? You, for the most part, have to plan ahead. They're not free. Some of them are not even cheap. They last different amounts of time, and so there are different levels of convenience, but certainly for the young women who aren't going to college and who are thinking about family stuff, they don't have $100,000 a year jobs, and so all of these methods are expensive for them. Condoms are expensive for them. The copays are expensive for them. It's quite expensive for this group, and a good chunk of them don't have insurance. So free contraception, or our Title X program just stays at the same level, which means it gets less and less valuable over time, right? The money level is pretty stagnant, but inflation continues to go. So there's a lot of poor women who don't have good access to contraception because of money.
You bring up a great point. If memory serves me correctly, Title X funding has remained the same in the past 9 years. But as you mentioned, inflation has not remained the same in the past 9 years. So affordable access to contraceptives is even more important than ever at this time, making sure that patients can contracept when they desire contraception and take control of their reproductive path is really important. And that's actually one of the things I'm really proud of at Afaxys is that we do support patients in that journey by providing affordable access to contraceptives. Thank you, Dr. Barber, for talking with me today. This was a really interesting conversation, and I really appreciate your time, and good luck with your study.
Thank you so much. Yeah, I really enjoyed talking with you too. Thank you for having me.